advances in immune modulation and rhinology. And basically, this is all these incredibly complex patients that Greg and Ian are sending to me. What the heck do you do with these? And really, I just wing it. But this is kind of how I go through. Those patients with chronic rhinosinusitis with nasal polyposis. And in those patients, do they have NSAID sensitivity? Oh, sorry.
Yeah, you can look at that one if you want. To your left.
Now it's kind of in my time here. Without NSAID sensitivity and asthma, and those without. So the first case, 46-year-old patient, has severe nasal polyposis, 3 polypectomies. You guys don't do a great job cleaning them out, but they come right back. The asthma almost always worsens when their nasal polyposis worsens, and in this patient, they have NSAID sensitivity. Whenever they take NSAIDs, they get a severe worsening of their asthma. So we all know this disease, AERD. It has a million different names, Samster's triad, but you have to have nasal polyps, asthma, and NSAID sensitivity. And a good history is often sufficient to diagnose this. So if they react, sinopulmonary reactions usually are indicative of this disease. So it's appropriate only for patients with this triad. So it's desensitizing these patients over a course of a couple days and basically inducing tolerance in these patients. And once we have them desensitized, they're continued on high-dose aspirin. 650 milligrams is what we keep them on indefinitely. And they've been shown in a lot of studies to have a significant benefit. Increased sinus infection or decreased sinus infections, decreased polypectomies, smell improves, nasal sinus symptom scores, asthma symptom scores, decreased needs for hospitalizations for asthma, which we like, and decreased systemic corticosteroid use. So the nice thing about this is aspirin is really cheap. One of the downsides is a few of these patients get gastritis, although it's surprisingly uncommon given the high doses that we have them on. People often need to go off for elective surgery. And the other thing is they need to take it consistently. So you need to get a very motivated patient population, which most of these are. So it's for patient not controlled on the standard therapies, which usually all these patients have. And the way we do it at our institution is Greg and Ian go and clean these patients out. And 4 to 6 weeks later, we do the desensitization. And that usually works best. If they're cleaned out, it's much better preventing those polyps from coming back. So a typical day, they come in at 8. We give them increasing doses of aspirin, nasal Toradol, and if things go well, they usually react, we treat it, and they go home by 4. The next day, they come in for a few hours, and if they get through it, they're desensitized, and they continue on high-dose aspirin, 650 milligrams BID. It sounds high, but they do really well on it. So what about the patients with nasal polyposis without NSAID sensitivity? Like this patient has had 2 polypectomies. Again, you guys clean them out really well. Feel great for a while, but they come back. Recently took ibuprofen and did not have any symptoms. So that kind of rules out AERD. So what the heck do we do with these patients? So there's a push in asthma to evaluate endotypes, not just phenotypes, but endotypes, a pathophysiologic mechanism. And the classic is Th2, which is very common in our asthma patients, but very common in nasal polyposis as well, with IgE, mediated inflammation, and eosinophilic inflammation as well. So we've had this forever, Xolair, anti-IgE therapy, and it works really well in our asthmatic patients with an elevated IgE and a perennial sensitivity. So in asthma, we've used it for a while, and it works really well for these patients, decreases exacerbations, decreases symptoms, and is prednisone sparing. So someone decided to use this in nasal polyposis. It's a smaller trial, but 23 subjects treated for 8 weeks, and the primary endpoint was endoscopic polyp scores after 16 weeks. Other indicators were they did CT scores before and after, nasal and asthma symptoms, and quality of life measures in these patients. And it worked really well. There was a significant decrease in endoscopic polyp scores in patients on Xolair. The CT scans also improved as well. Symptoms also improved as well, decreased nasal congestion, anterior rhinorrhea, loss of sense of smell, and wheezing and dyspnea, not surprising. And this was a very short course. So what about other things? Mepolizumab was just approved for asthma, and we love this medication. It's worked really well for our asthmatic patients, and it's an anti-IL-5, and IL-5 drives eosinophilic inflammation. In our asthma studies, it decreases exacerbations, increases FEV1 or lung function, and is prednisone sparing, which is really important in these groups. So basically, the same group did the same trial, and 30 patients treated with 2 doses, just 2 doses of Mepolizumab. And they had similar findings. 12 of the 20 in the Mepolizumab group had a significant decline in nasal polyps. And also, smell, postnasal drip, and nasal congestion all improved in these patients as well. So we're likely also going to have other agents in the future. Dupilumab is going to come out for asthma soon, but they did another trial similar to the previous 2 in 60 adults and found the same thing. So the pros of biologic agents is they're really well tolerated. It really doesn't impair immunity that much. But the cons are the cost at this point. So you have to get this approved by insurance. So they have to have asthma in this case. So next case, someone without nasal polyposis and 4 to 5 episodes of sinusitis per year. There's also otitis media, pneumonia, and the lab workup shows your diagnosis. That's something called common variable immunodeficiency, which, as the name suggests, is very common. And primary immunodeficiency, we're finding it more and more now that we know more and more about it. And we're on the front lines of this in adults. They typically present with recurrent sinopulmonary infections, sinus infections, ear infections. And the treatment for this condition is IVIG, which not only can improve nasal symptoms, but also can prevent other life-threatening infections moving forward. So for patients with nasal polyposis, if they have NSAID sensitivity, consider aspirin desensitization. Without, if they have severe asthma, consider having them checked out for a biologic agent. They may qualify and it works pretty well. If they don't have nasal polyposis, then I loved it. I heard this brought up earlier that immune deficiency can be an underlying cause, which can change their management. So, whew.
Great job.